This is very interesting. I was giving a lecture today to residents, and then I was telling them a little bit about the history of approval of immunotherapy, right? Because it all started with melanoma. And immunotherapy has been studied for years, but immunotherapy is also not only checkpoint inhibitors. When you talk about immunotherapy nowadays, we're referring to a lot checkpoint inhibitors, because that's what really changed the way we practice, right? But we learned a lot from melanoma, and we still do, because that's the first disease that checkpoint inhibitors were approved and show major improvement in survival, right? So I remember when I was a medical student, one of the first trials with one of the checkpoint inhibitors was being conducted. I was rotating here in the United States, and that paper was published later in 2012. So it's not that long ago that these therapies became available for other solid tumors, right? And I think what we learned over the years is that, well, second line and beyond, initially, that's how it was studied. Like nivolumab was the first immunotherapy checkpoint inhibitor in non-small cell lung cancer that was studied approximately 6 years ago. The trial was published, and then we saw great results, and that's coming out from data in melanoma, again, that we learned. And then we had pembrolizumab, and then atezolizumab, and now we have durvalumab, cemiplimab, and all these checkpoint inhibitors became available. But it all started with information that we learned from other solid tumors, and then we translated the findings to non-small cell lung cancer. And although the treatment paradigm has shifted, because I remember when I was still in training, we were giving a lot of checkpoint inhibitors in second line, and halfway through my training, it's like, nope, now we're giving checkpoint inhibitors in first line. So things are changing very fast. And it's all in the past decade for lung cancer in reality. So ongoing research, there's a lot of studies with combinations of immunotherapy and CAR T cells or tumor-infiltrating lymphocytes or macrophages. So it's very interesting. So basically you remove parts of someone's tumor, and then you culture the lymphocytes in the lab, and then you infuse it back and you give immunotherapy, or you do that with macrophages. So it's all this, what we call cellular therapies combination. So there's a lot of that because we know the immunotherapy, for it to work, checkpoint inhibitors needs to find the cancer cells. And sometimes if there's not a lot of immune cells in that area, this is what we call cold tumor, checkpoint inhibitors may not work. So you need kind of to reset your immune system to infiltrate that area so that the checkpoint inhibitor can work. So that's why the cellular therapies, I think, will be the next step. I think they are very promising. They work very well for lymphomas and liquid tumors. There's a lot of research. And also there are combinations that were recently approved last year. There was a Checkmate 9LA that the full manuscript was published this year, that is combining ipilimumab, nivolumab with a platinum doublet. That's the latest approval. Then there's also another combination, ipilimumab and nivolumab, that was also published, the full paper last year. And there's new biomarkers that we're also studying to see if they can stratify patients and see who respond better to checkpoint inhibitors or not, like tumor mutational burden, not only PD-L1. But I think the future is the cellular therapy combinations with checkpoint inhibitors to kind of reset the cancer on patients that the disease became resistant to checkpoint inhibitors. There's also some combinations with target agents. So I think that's the way to go for antibody drug conjugates.